Within this video, we have used a trolley for equipment. We understand that trays and designated workspaces may be used depending on your places of work. The same efforts should be made to clean and reduce the risk of infection. We use the term patient and understand also this may not be appropriate in all scenarios, but for ease of the course, we decided on one term. When you first meet with the patient, you should explain and discuss the procedure so that they understand what is happening and give their informed consent. It is vital that patients' privacy and dignity is respected. Wash hands with soap and water using 6-step hand washing technique. Prepare trolley starting from the top furthest away from you and working your way methodically down. If not using a trolley, prepare your dedicated tray or working environment following ANTT, an infection control policy. For this procedure, you will need sterile dressing, low-linting gauze, which may be in the sterile pack, cleaning solution, tracheostomy dressing as prescribed or trachea wipes, tracheostomy tape, alcohol hand rub. Remove the tapes and old dressing from around the tube. Clean around the stoma with cleaning solution, using low-linting gauze to reduce lint entering airway. Clear airway must be maintained throughout and not covered with hands or dressings. The airway is clear throughout this video, but in parts may be difficult to see due to the angle used. Replace with a tracheostomy dressing as prescribed to ensure patient's comfort and reduce pressure from the tube. Renew tracheostomy tapes, checking that 1 or 2 fingers can be inserted between tape and neck in order to keep tube secure and decrease the chance of necrosis due to pressure from tube. Monitor your patient for any change in the respiratory rate, breathing pattern, pulse and dyspnea, as any procedure to tracheostomy may cause dislodgement or secretions, leading to respiratory deterioration or distress. Remove gloves and apron, disposing in clinical waste. Wash your hands using the 6-step technique or use alcohol hand rub. Assist patient with cleaning, dressing and repositioning if support is required. This gives you the opportunity to answer any questions the patient may have. Draw back the curtains, leave the room as the patient wishes to support and encourage person-centered care. Record information in relevant documents. This should include reasons for tracheostomy, date and time, dressing type, any problems during the procedure, review date. Tracheostomy suctioning, pre-procedure. Preparing for the procedure, please ensure hands are washed using 6 steps hand washing technique and that trolley is methodically cleaned as previously shown. For this procedure, you will need portable wall suction with collection canister and tubing, sterile suction catheters sizes as prescribed, non-sterile gloves, sterile bottled water labelled suction to be changed daily, apron, eye protection if required, alcohol hand rub. Ensure that a non-fenestrated inner tube is in situ during suction to prevent the suction catheter passing to the tracheal wall. Suction via a fenestrated inner tube allows a catheter to pass to the tracheal wall. Procedure. Wash hands with soap and water to put on disposable apron, gloves and eyes, mouth protection. This is to minimise the risk of cross-infection. Gloves minimise the risk of infection transfer to the catheter. Some patients may cough, so goggles and a mask may be necessary to reduce cross-infection. If your patient is oxygen dependent, hyperoxygenate for 3 minutes to minimise risk of acute hypoxia. Ensure suction pressure is set to appropriate level. Under 100 to 120 mm of mercury is recommended to minimise atelectasis. Check per care plan. Select correct size catheter as prescribed. This reduces chances of hypoxia while suctioning. The larger the volume, the larger the bore of the tube. Incorrect choice can cause mucosal damage. Too small a tube may be unable to remove thick secretions. Discuss with your patient how to make you aware should they be in discomfort so you know to stop. Open the end of the catheter pack and use pack to attach to the suctioning tubing. Keep rest of the tube in the pack using aseptic non-touch technique throughout to reduce the risk of transferring infection from hand to catheter and to keep clean. Remove the suction catheter from the sleeve, ensuring that the tip of the catheter up to the length of insertion does not come into contact with anything such as gloves, patient's clothing, skin, etc. The catheter should be inserted with the suction off to avoid trauma, and only cover the hole on the suction catheter with your thumb when removing the suction catheter. Observe, monitor and assess patient during procedure, talking and reassuring throughout. If resistance is felt, withdraw approximately 1 centimeter before applying suction and placing thumb across suction port and slowly remove the rest of the catheter. Being gentle is essential as damage to the tracheal mucosa can cause respiratory infection. The catheter should go no further than the carina to avoid trauma. The catheter should be inserted with suction off to avoid trauma. Always check care plan for length to be inserted. Do not suction your patient for more than 10 seconds as prolonged suctioning can result in acute hypoxia, cardiac arrhythmia, mucosal trauma or infection. The patient may also feel they are choking. Wrap the catheter around your main hand and pull back your glove over the used catheter containing it within your glove. Then discard. A catheter should only be used once to reduce the risk of infection. If your patient is oxygen dependent, reapply oxygen to prevent hypoxia. If further suctioning is required, repeat all steps using a new catheter. Allow your patient sufficient time to recover between suctioning, particularly if oxygen dependent. Repeat the suction until the airway is clear. Do not exceed more than 3 suction passes in one sitting unless in an emergency. Inform patient when the procedure is complete. Post-procedure. Where appropriate, reconnect your patient to oxygen within 10 seconds of finishing the procedure to minimize the risk of hypoxemia. Maintain observations for 15 minutes of patient's respiratory rate, pattern, oxygen saturation and heart rate. Also look for any signs of bleeding. Dispose of equipment in a yellow plastic clinical waste bag and seal the bag before moving the trolley to prevent environmental contamination. Hands should be decontaminated using soap and water with 6 steps hand washing technique or alcohol hand rub. Assist patient with cleaning, dressing and repositioning if support is required. This gives the opportunity to answer any questions. Draw back the curtains, leave the room as patient wishes to support and encourage with person-centered care. Record information in relevant documents. This should include reason for tracheostomy care, date and time, catheter size and type, any problems during the procedure, review date. Tracheostomy in a cannula change. Pre-procedure. Explain and discuss the procedure with the patient to ensure that the patient understands the procedure and gives their informed consent. Ensure the emergency trolley is available and inform other staff members which procedure is about to take place in case help is required. In case of difficulty replacing airway and to ensure all staff are aware. In case of difficulty replacing airway, ensure all staff are aware that a tracheostomy is being changed and in the event of complications they are able to assist. Recheck suction and oxygen supply. Ensure spare tubes, dilators and all emergency equipment are readily available to ensure patient safety in the event of inability to secure airway with new tube. Procedure. Perform the procedure using clean technique, avoiding touching parts that will be inserted into the outer cannula to minimize the risk of infection. For this procedure you will need non-sterile gloves, low-linting gauze, replacement inner cannula, alcohol hand rub. Assist patient to sit in a semi-recumbent position with neck extended to help with comfort and maintain airway as patent. Extending the neck will make removal and insertion of the tube easier, ensuring privacy and dignity. Some patients may cough accidentally directly ahead at the nurse. Standing to one side and wearing appropriate apron and eye protection will minimize the risk of secretions being transferred. Hands should be decontaminated using soap and water using 6 steps hand washing technique, putting on gloves and apron before the procedure to reduce infection. Remove the inner cannula. If disposable, dispose in clinical waste. If non-disposable, please clean as per manufacturer's instructions. Placing gauze under the tracheostomy in case of any loose secretions. Do not soak in cleansing solution due to bacterial colonization and absorption of the solution, which can cause irritation. Place the new inner tube in position and ensure it's in a locked position to re-establish airway and prevent cannula from dislodging. Hands should be decontaminated using soap and water with 6 steps hand washing technique or alcohol hand rub. Post-procedure. Post-procedure, you should observe your patient's respiratory rate and pattern, oxygen saturations, heart rate, and work of breathing closely over the following 15 minutes. Observe for signs of bleeding, as changing a tube can cause respiratory distress in patients. Dispose of equipment in a yellow plastic clinical waste bag and seal the bag before moving the trolley to prevent environmental contamination. Assist patient with cleaning, dressing and repositioning if support is required. This gives the opportunity to answer any questions. Draw back the curtains, leave the room as patient wishes to support and encourage with person-centered care. Hands should be decontaminated using soap and water with 6 steps hand washing technique or alcohol hand rub. Record information in relevant documents. This should include reason for tracheostomy care, date and time, tube size and type, any problems during the procedure, review date. Tracheostomy tube change. Pre-procedure. When you meet with the patient, you should explain and discuss the procedure so they understand what is happening and give their informed consent to the procedure. Ensure the emergency trolley is available and inform other staff members which procedure is about to take place to assure all staff are aware that airway is being changed and in the event of complications are able to assist. Recheck suction and oxygen supply. Ensure spare tubes, dilators, and all emergency equipment are readily available to ensure patient safety. Wash your hands using soap and water or hand rub to minimize the risk of infection and prepare a dressing trolley. Screen patient's bed to ensure patient privacy. Always perform the procedure with a second appropriately trained person to ensure patient safety at all times. Perform the procedure using aseptic non-touch technique to minimize the risk of infection. For this procedure, you will need sterile dressing pack, tracheostomy dressing, tracheostomy tape, cleaning solution or trachea wipes, lubricating jelly, hand rub, eye protection, apron. To help with comfort and maintain airway as patent. If the patient is able to extend their neck, it will make removal and insertion of the tube easier. Wash hands using soap and water with 6-step hand washing technique. If the new tracheostomy is cuffed, check the cuff by inflating it with air, according to manufacturer's instructions. Then fully deflate the cuff in order to check for air leaks and spontaneous deflation. Insert the introducer or obturator of the new tube, checking that it can be easily removed to become familiar with removing the introducer or obturator prior to insertion. Lubricate the new tube sparingly with a lubricating jelly and place on the sterile dressing surface to facilitate insertion and maintain sterility. Thread the new tapes or ties through the slit of one of the flanges, which can be done prior to insertion whilst maintaining sterility. If the old tube is cuffed, slowly deflate the cuff, suctioning patient if required. Pooled secretions above the cuff may enter the lungs when the cuff is deflated. Gently remove the soiled tube from the patient's neck while asking the patient to breathe out. Conscious expiration relaxes the patient and reduces the risk of coughing. Coughing can result in unwanted closure of the tracheostomy. Quickly clean in downward single strokes, ensuring not to block airway or force cleaning solution or secretions into the airway. Apply barrier cream with topical swabs if prescribed. Provide care efficiently and be organised with equipment so as not to prolong the time the patient is without a formal airway and/or oxygen. Put the tracheostomy dressing around the tube. Dressing can be used as an effective barrier to prevent bacteria from entering the site. Insert a clean tube with introducer in place using an up and over action. Introduction of the tube is less traumatic if directed along the contour of the trachea. Remove the introducer immediately as the patient cannot breathe while the introducer is in place. Place the inner tube into position. The inner tube can be changed as necessary when the outer tube is in position, thus minimizing the risk of trauma to trachea and stoma. The quantity of secretions present will determine the frequency with which the inner tube is changed. Ensure the tapes are secure with a space from skin to tie of 1 to 2 fingers only. This will secure the tube while at the same time ensuring patient comfort and reduction in pressure damage to the neck and stoma site. Ensure airway is maintained and clear throughout the procedure. This can sometimes be difficult to view on screen due to filming angles. Remove gloves and ask the patient to breathe out onto the palm of your hand. Flow of air will be felt if the tube is in the correct position. Remove gloves, apron and clear away the trolley and equipment. Dispose of all single-use tracheostomy tubes immediately in contaminated waste. For long-term reusable tubes, clean the soiled tube with sterile water or in line with the manufacturer's recommendations. Plastic tubes should not be soaked in solutions. Post-procedure. Post-procedure, you should observe your patient's respiratory rate and pattern, oxygen saturations, heart rate, and work of breathing closely over the following 15 minutes. Observe for signs of bleeding as changing a tube can cause respiratory distress in patients. Insertion of new tubes can cause bleeding. Dispose of equipment in a yellow plastic clinical waste bag and seal the bag before moving the trolley. Wash hands using soap and water with 6-step hand washing technique. Assist patient with cleaning, dressing and repositioning if support is required. This gives the opportunity for you to answer any questions the patient may have. Draw back the curtains, leave the room as the patient wishes to support and encourage with person-centered care. Record information in relevant documents. This should include reason for tracheostomy care, date and time, tube size and type, any problems during the procedure, review date. Wash hands using soap and water with 6-step hand washing technique.